Before unpacking common labor interventions, I want you to know why interventions might be used during your labor. There's a number of different reasons why your care provider might feel you need an intervention, and oftentimes it's going to depend on your birth environment. There are far less interventions used in a home birth environment and even a birth center environment than there would be at a hospital. So, getting clarity from your care provider about what interventions are available to you or might be suggested to you is definitely an important part of creating your birth preferences. But the bottom line is most interventions are offered to keep you safe. They're there to intervene and protect you and your baby from a potentially bad outcome. But sometimes interventions can be overused, and oftentimes they might not be necessary. So, that clear communication with your care provider and informed consent will really help support you in having an empowered experience when it comes to interventions. Let's walk through the most common interventions that you might encounter in any birth environment. Let's talk about a Heplock or saline lock. It's basically just a fancy name for an IV or intravenous going into your vein catheter. And a catheter is just a rubber tube that takes fluid from one place to another. Now, here's what's important. That catheter is going to be placed into your arm. Now, you want to make sure that it's not placed into your hand. Some care providers will try to do that, and I really don't like having catheters or any type of IV placement in the hand because it can make it really hard when you're trying to move around or when you're trying to breast or body feed your baby after birth. So try to make sure it's placed in your arm and also on your non-dominant arm, the arm that you don't typically write or read or drive with. The next intervention is IV fluids. Behind me, I have a bag of lactated ringers, which is actually just a fancy name for electrolytes with water. Now, IV fluids can be offered to you in a hospital or even in the home setting for a couple of different reasons. The first reason being wanting to make sure that you're having enough fluids circulating in your system to maintain a healthy blood pressure, especially when you're not eating or drinking a lot during labor, which definitely happens because when you're going through a high intensity event, your desire to eat and drink really drops. The second reason might be if you're planning on having a medicated birth and using an epidural. Having enough fluids in your system is important before you get your epidural to make sure that your blood pressure doesn't drop as soon as you get it, because that can sometimes happen once that medication is administered in the body. Now, going back to the Heplock for a moment, thinking about blood pressure, one of the reasons why, especially in a hospital setting and primarily in a hospital setting, you might be encouraged to have a Heplock or a saline lock is because to try and place the Heplock or saline lock in a time of high pressure can be very challenging. When you're stressed or panicked or scared, your blood vessels become harder to contact and it becomes harder to place the IV catheter. If you're planning to have an unmedicated birth and you're birthing in a hospital, it does make sense to negotiate to not have a Heplock or saline lock so that you can move around more comfortably. But if you already know that your plan is to have a medicated birth, having that Heplock placed early is actually going to be really helpful to save you from having to go through that process right before trying to have your epidural given to you. Another intervention in labor is monitoring. And there's two ways that monitoring can take place. There is continuous monitoring, which means you are constantly being monitored and your baby is constantly being monitored during labor. And then there is intermittent monitoring, which means that both you and your baby have periods of being monitored and not being monitored. There's a couple different ways that monitoring can happen. It can be pretty lo-fi and hands-off using something called a Doppler, which both a doctor or midwife can use to find just your baby's heartbeat. A little bit of gels placed on the top here on the transducer, and then it's placed on your belly until they find the heartbeat. What I love about Dopplers is that they are small, handheld, easy to get into nooks and crannies, especially if you're moving around during labor, and they really are not invasive. And then we have these belts. And you'll find these belts in a hospital setting. And they're used to help keep two devices strapped to your belly. One will be for your baby, and that will monitor your baby's heart rate. And the other will be for you, and that will monitor the frequency of your contractions. This type of monitoring can be continuous or intermittent. If it's continuous, you'll have these belts on along with the monitors for the entire labor. And that will happen if you decide to have a medicated birth, because when you have an epidural, you need constant monitoring, or if there's any other medically dictated reason why you and your baby need to be monitored throughout your labor. Another form of monitoring is internal monitoring. And the focus for this monitoring is to get your baby's heart tones and to also figure out the frequency of your contractions. What's happening when internal monitoring is suggested typically means your bag of waters has broken and your provider is struggling to get a good read on the frequency of your contractions with the exterior monitoring or external monitoring belts that I just showed you. So what they tend to do to find out if you're still contracting regularly and also to track your baby's heartbeat are two things. A fetal electrode is placed into the vagina, and the electrode is placed on the caput, also known as a soft spot of your baby's head, to monitor your baby's heart rate. The reason that that monitoring needs to happen is to make sure that there aren't a lot of decelerations. Decelerations are what happens when you have a contraction, your baby's whole body is squeezed, and as a result, their heart rate goes down as your contraction gets stronger. As soon as your contraction is done, what should happen is your baby's heart rate should go back up as your contraction releases. Sometimes, as your contraction releases, your baby's heart rate stays low. That's a deceleration. Decelerations are absolutely normal in labor, and they're to be expected. However, many decelerations in a row can be a cause for concern. And that's why monitoring is necessary on an intermittent basis at the very least, and sometimes continuously, and maybe at a more in-depth level with something like internal monitoring. And then the other component of internal monitoring is the pressure catheter that's inserted into the vagina, like so, in order to monitor the frequency of your contractions alongside the heartbeat of your baby. Another intervention that might be used is a bladder catheter. And the reason why you might have a bladder catheter could be because as your baby gets lower and lower in your pelvis and you're just about ready to push out your baby, sometimes your bladder, when it's full, creates some difficulty when pushing. An empty bladder and an empty stomach can make it easier for your contractions to work more effectively. So sometimes your provider might say that they want to put a catheter in so they can make more room for the baby. If you're having a medicated birth, you'll be numbed before the bladder catheter is placed into your urethra, which is the hole where your urine comes out of. Although it looks like it's going into your vagina, it's actually going into your urethra. And if you're having an unmedicated birth and you need a catheter, your baby's going to be so low that it actually won't be that uncomfortable to have the catheter placed into your urethra because you'll already have so much pressure in that area. It should feel like a release actually to have your bladder drained. Another thing I want to talk about is forceps. Forceps are two metal spoons that fit along the side of your baby's head and can be used to help guide or pull the baby out as you push. The fetal risks with forceps are lower, but there's a higher degree of potential maternal risks. So that's something, again, to keep in mind as you're building your birth preferences. It's another decision you'll need to make from a place of informed consent. Another intervention that could be used during your birth might be a vacuum, which would come in at the final stage of labor when you're pushing your baby out. A quick word about vacuums. A vacuum is only going to be recommended by your care provider if there are a few other key components at play that could result in a positive outcome of using a vacuum. So let's talk about those. as you can see, I have my pelvis here. And in terms of when a vacuum could be used, your baby needs to be very low down in your pelvis. Your baby actually needs to be at least +2 station. So that's really, really low. And the reason for that is so that there's easy access for your care provider to get the vacuum onto your baby's head. When the vacuum is on your baby's head, you and the vacuum and your baby, all three of you, are going to work together. So as you have a contraction, you're going to push, your baby's going to move, and the vacuum is going to be turned on all at the same time. And so the vacuum essentially triple charges your uterine contraction to try and create as much external force to bring the baby out on top of the internal forces of gravity, you and your baby working together to try and push your baby out. Now, a vacuum is only going to be used for about 4 pushes or for about 25 minutes. It's a very short-term intervention. It's important to keep in mind that vacuums have higher fetal risk, so more risk to the baby, and a lower maternal risk, meaning less is possible to harm or happen to you. And it's going to be important for you to weigh out those risks and come to the decision from a place of informed consent should you choose to use a vacuum. My personal feeling about vacuums is that when they are offered, it's always because your care provider thinks that this might get us where we need to go. And by that, I mean it might get us to a vaginal delivery. Now, if you feel concerned about increasing risk to your baby, you might elect to have a cesarean birth out of a desire to not really have any more intensity added to your baby's birth experience as a result of the external vacuum. That said, if a vacuum is given to you as an option, I always think it's worth giving it a try, especially if you feel like you have some extra oomph left in your system to do some really strong pushing.